নমস্কার। ইলেটস ফিফথ হেলথ কেয়ার লিডার্স ফোরাম 2015 আপনাদের সবাইকে স্বাগত। নমস্কার। I, on behalf of Ilets Technomedia, welcome you all in Ilets fifth Healthcare Leaders Forum, Bengal. East shows the way. It used to be said once that what Bengal thinks today, India thinks tomorrow. And under the new leadership in Bengal, the state has embarked upon the journey of changing the face of the state in all sectors. Health sector too has been given utmost priority. But it is also true that the East Indian region is plagued with almost similar ailments as the entire healthcare sector in the country. With quality medical services being confined to the urban centers of the eastern region, the rural pockets hold tremendous opportunity for the healthcare service providers to deliver quality care. At the Healthcare Leaders Forum Bengal today, we aim to provide a vibrant platform for the innovators, investors, and to engage private companies with the East region hospitals and healthcare service providers, and also enable the healthcare services providers to exchange knowledge and best practices with each and other for better healthcare system in Eastern India. The objective of the forum is to bring forward the healthcare technology initiatives taken to facilitate quality care in the eastern part of India. ILITS, through its journey over the years, has been instrumental in creating thought-provoking and engaging platform across the country. As we come to the end of 2015, we at ILITS are looking forward to our presence in the eastern part of the country and contribute towards the growth and betterment of healthcare services in the region through our various platforms. Health has been one of the key focus area of ILITS, and we have been enablers of initiating effective dialogue exchange between various stakeholders through our health summits this year in Delhi, Jaipur, and the most recent one in Mumbai as part of our E-India Maharashtra Summit offering. Eastern part of India has high potential for healthcare transformation, and this summit tries to collaborate those change makers. We welcome all our esteemed guests today. The inaugural session will focus on healthcare policy and initiatives in Bengal. And to discuss these policies and initiatives, we have galaxy of stars from government, from industry, and we'll call them on stage one by one. I'll request Mr. Upenderjit Singh, Managing Director, West Bengal Electronic Industry Development Corporation Limited, WEBIL, to join us on stage for the inaugural. A big round of applause for him, sir. I request Dr. Akun Savalwal, Director, Drugs Control Administration, Government of Telangana. A big round of applause for him. I request Dr. Shujoy Kaur, Director, Medical Services, Apollo Clinical Hospitals. Mr. Shujoy Kaur, please. Yeah, a big round of applause for him. I invite Dr. N.C. Bora, CMD, GNRC Hospital, Assam, to join us on stage. And as we have said that ILITS conference is all about gapping the bridge between government and industry. So I welcome Mr. Kieran McBrien, Regional Director EMEA of Novartis Limited, Ireland. A big round of applause for him, please. I request my colleague Priyanka to come on stage and welcome our esteemed panelists for the inaugural section. To start off with Mr. Upenderjit Singh, WEBIL MD. Dr. Akun Sabarwal. Kieran McBrien. Dr. Shujoy Kaur. Dr. N.C. Bora. As we know that it's a part of Indian tradition, whatever new thing we start with the lamp lighting. So I'll request all the speakers, eminent speakers for the inaugural section to join us for the formal lamp lighting ceremony. Can we have a big round of applause for the... We'll listen to the visions shared by the eminent speakers in Inaugural, but before that, just to give an overview of what ailments do, and just to share with you all what we do, pan-Indian abroad also, I'll request my colleague Priyanka to come on stage and give a presentation on all ailments initiatives.
Very good morning to everyone. As Mr. Souvik has said that this is the first time we have come to East, so this is an opportunity for us to introduce about ailments and eHealth magazine, what we do, what our aims, and why we are here. So I would request you to display the Priya. So ailments Technomedia was started in 1997. We have 4 publications, apart from our digital presence, financial inclusion, governance, education, healthcare, and banking and finance sector. A brief, we believe in information and communication technology to open new avenues of innovations not only in India, but abroad as well. Our initiatives, we have publication, knowledge portals, which you can visit anytime. Our digital presence is worldwide. Summits and awards like one we are doing right now, and expos. Publications, as I said, we have 4 major sectors we cater to. It's banking and finance, e-governance, digital learning magazine for education, and e-health for healthcare sector. Our knowledge portals, we engage key innovators, politicians, policy makers in our magazine, plus the corporates, and we try to provide a common platform to connect a bridge between the government officials and the corporates. These are our few screenshots of our knowledge portals. Our weekly newsletter, you can subscribe to our weekly newsletter and stay updated in what's happening in the sectors of banking, education, governance, and health. These are the links where you can see our website. These are the link for all the website for all our portals. The landmark summit with a visionary approach and well-defined session. This is the aim of why we do conferences and what is the purpose of doing conferences in our all 4 verticals. Provide unique opportunity to engage with the broad range of stakeholders. Stakeholders discuss latest trends, business models, and emerging technologies, bringing change for masses and leading to inclusive growth across borders. And we also seek for the partnership between the government and the private sector, where they can come and collaborate and innovate for the betterment of the country. These are the few pictures of our past summits. This is the summit which we did in Bangladesh, and not only in India, we have our approach overseas. This was the stamp which was posted by our organization, which was officially accepted by the government of Bangladesh, and it was released by the Honorable Prime Minister of Srimati Sheikh Hasina. Awards, the aim of awards is to recognize the new initiatives which are happening in the country and to give them, bring them in the limelight in the knowledge of the government and the whole world. These are the few pictures of our past award ceremony. These are pictures of our expos which we do. These are the few events which we have done in previous year with the government and without the government. These are the overseas presence, not only in India but outside India as well. This is the event which we did with the government of Rajasthan. National Health Mission was supported us for this conference, one of the big success of this year. This happened in Jaipur. These are the few pictures. The health minister joined us at the conference. He was our chief guest. This was the event happened in New Delhi in this year, in the beginning. So this happened in New Delhi in the March. These are the few CMs who has come to our conferences, whether it's from governance, education, or health. And these are the few government organizations who always supported us for our conferences. Few international partners of ours. Our government partners in past years, in coming years. Our corporate partners, very important part of all our conferences, our corporate partners. PSU partners, we do PSU conclaves as well. And these are the PSUs where partners have supported us for such conferences. Our banking partner, a very close connection we maintain with the banks. So let's keep in touch. If you have any query, if you have wants to know more about ELETS and what we do, you can just write to us on info@elets.in. This is the social page for our eHealth magazine. We've been tweeting live. So I would request you to please go on our pages, our LinkedIn and on our on our Twitter page, so that you could also tweet and retweet your what's all is happening over here to your followers. So thank you so much, and we hope this day will end with a good note and the purpose of knowledge sharing is fulfilled by everyone. Thank you.
Thanks, Priyanka. Thanks a lot. And as she has mentioned that partners are important for growth. And in this context, I want to thank our associate partner, Trivector, supporting partners, Webel, and Association of Medical Hospitals of Eastern India. So now we'll start the inaugural session with the speeches and vision sharing, knowledge sharing. To start off with, I'm going to request Mr. Kieran McBrien, Regional Director EMEA of Novartis Limited Ireland, to come and speak and share his vision. Just to give a brief introduction to him, Mr. McBrien is based in Germany. He's the Regional Director for EMEA region for Novartis Ireland, the company which has revolutionized the airborne infection control with world's most advanced plasma-based infection control technology. He has completed MBA in marketing from Ulster University, an entrepreneur to the core. Kieran is dynamic, passionate, and creative businessman who has acted in various capacities, including CEO of a couple of companies. It is his second visit to India in a span of 2 weeks on an invitation of Trivector Biomed, his exclusive Indian partner for Novartis products. We welcome you, sir. Please.
So thank you once again. As my colleague just said, this is my second time in India, but it's my first time in the most important part of India. It's my first time in Calcutta. The gentleman said earlier, where Calcutta leads, the rest of India follows. I don't know if that's true. I hope it's true. I'm sure it's true. Oh, he said used to be. Okay, fair enough. Anyway, it's my first time here in your wonderful city. I'm very pleased to be here, and thank you for the welcome. I hope I'm going to say some things that you find interesting. When making a presentation or a speech, I always try to follow the advice that Lady Churchill once gave to Winston Churchill before he made a speech in the House of Commons. She said to him, when he asked her advice, "Winston," she said, "for a speech to be immortal, it does not have to be eternal." So I'll try and keep to that motto today and not make this an eternal presentation. I will go quickly and rapidly because I know that I'm faced with a room of very intelligent people who will be able to read what's on my slides much quicker than I'll be able to say it. So, airborne infection control. Our vision is that clearly hospital infections acquired in hospitals is a massive issue across the entire world, not only in India, but let me give you one very frightening statistic to take a country a long way away from here. In the Federal Republic of Germany, there's a lot of focus on reducing traffic accidents. Traffic accidents in Germany kill around 4,000 people every year, which is clearly 4,000 people too many. And a lot of money and investment is put into road safety to bring this number down. The number of people in that country who die from nosocomial or hospital-acquired infections is, depending on who you believe, somewhere between 30 and 40,000. So approximately 10 times the number of people who die in road traffic accidents. So that is a very, very high number. And I sometimes wonder what people are really doing about it. But that's perhaps a discussion for another day. So clearly the point is it's a Very serious problem, and we need to be doing more about it. And in our view, to start off by being controversial, in my view, it's not enough to keep on doing what we've been doing for 150 years, or in some cases, 1,500 years. Arab doctors were washing their hands with vinegar 1,500 years ago before carrying out procedures. We haven't moved on terribly far from that, in our view. And in our view, quite clearly, to put together a complete infection control problem, you have to start at the beginning. You have to close the infection control loop. You have to sterilize the air. You have to clean the air before you do anything else. And I'm always looking for examples. And as I stepped onto the platform today, I saw this. It's a drinking glass for drinking water. And what's on the top of it? Why is that on the top of it? That's on the top of it to prevent pathogens settling from the air into the glass. There you have a classic example of a preventative, proactive, prophylactic, simple technology. And this little plastic circle, I'd like you to keep that in your minds as a symbol, as a representation of what Noveris does. Noveris is a preventative, prophylactic, proactive technology which prevents the transmission of pathogens through the air and the settlement of pathogens on surfaces. I have to stop doing that. So, pathogens are in the air, and I'm going to show you some evidence. By treating pathogens in the air, you do two things. You do, well, 2.5 things. You remove the pathogens from the air which are traditionally associated with airborne transmission, tuberculosis, influenza, measles, etc. You also block the passageway of a wide range of other pathogens which can be made to become airborne. And we'll speak about some of those in a minute. Thirdly, by preventatively, proactively, prophylactically treating the air 24 hours a day, you reduce the danger, you reduce the load on surfaces, you reduce pollution, you reduce the bioburden on all fomites. Just like this little circle prevents pollution in that glass. And obviously and logically, if you're continuously cleaning your environment, if you're always reducing the pollution or the bioburden on surfaces, by definition, logically, you're reducing the number of contact points and the danger of contact points for hands. It's simple, it's logic. So, pathogens are in the air. Now, clearly, I'm going to talk in a moment about MRSA. For example, MRSA, they don't have little wings, they don't fly around the place, but they can be made to become airborne. We shed skin cells, we cough, we emit particles. And evidence shows that these particles will travel around environments much more quickly and at greater distances than previously thought. Commonplace practices, changing the beds. It's now protocol when changing a bed not to flap the sheets around in the wind, but to carefully insert them into a bag, which is great. Except, what is an empty laundry bag full of before I put the laundry into it? A prize for the best answer. What is an empty laundry bag full of? Do I hear someone saying air? An empty laundry bag is clearly full of air before I fill it. I fill it with my laundry. Where has the air gone? It's no longer in the bag, it's in the room, taking with it some of the pathogens present in the laundry. So, a variety of procedures put pathogens into the air. Flushing a toilet puts pathogens into the air. Changing beds puts pathogens into the air, etc. Some studies. This is a study from the University of Hong Kong, University City London, after the SARS epidemic in 2003, specifically looking at the mechanics of transmission of particles around an environment. Now, for study purposes, this was a sealed room with no air currents. And you can see there, in a room with no air currents, particles remained in the air for very long periods of time. Viral particles remaining airborne almost indefinitely. Now, the traditional view has been we clean surfaces, because particles fall very quickly to surfaces and can therefore be mopped up at that point. But at this point, I have to say that we're applying the wrong branch of science to this analysis. This is not biology at this point, ladies and gentlemen, it's physics. It's not biology, it's physics. And what do I mean by that? Well, let me give you another example. I came to India on, I think, Tuesday or Monday, some day recently anyway, and I traveled to India on a very large particle, which weighed well over 200 tons, almost 300 tons, and this particle stayed in the air for 8 hours. And it traveled all the way from Frankfurt, Germany, to Mumbai here in India. Very large particle stayed in the air. Why did that particle stay in the air? It stayed in the air because the forces keeping it in the air were greater than the forces of gravity, pulling it down. And the same thing applies to microscopic particles. If the forces keeping them in the air are greater than the force of gravity, they will stay in the air until that relationship changes. And they will travel around your facility and remain infectious in the air. All of these people, and many more research institutions besides, are recognizing the fact that many kinds of pathogens, many kinds of infections, which we did not traditionally think to be airborne, are in fact also airborne. Influenza research showing that the tiniest particles can be up to 9 times more infectious than traditional droplet nuclei and can stay airborne almost indefinitely. Norovirus in healthcare facilities in the United States, Johns Hopkins and other universities are saying this is now definitely shown to be also transmitted via the airborne route. Research from Canada from this year in 8 different facilities, taking norovirus just as one example, showing norovirus present in airborne samples in 8 different facilities extensively throughout the critical environments and locations in those hospitals. Research from this year from Canada. Clostridium difficile, research from Leeds in 2011, using DNA fingerprinting, tracking individual spores from individual patients to different locations inside the ward, also up to high locations, to high fomites, where no possible traditional contact was possible. Airborne. MRSA, this is research from last year published in the Journal of Hospital Infection, showing in a large teaching hospital in Dublin and Ireland, clear evidence of MRSA, live culturable MRSA in the air around many locations in the hospital. You'll note there the particular vulnerability of the high dependency units. You will also note significant presence of MRSA in locations where there had never been an MRSA positive patient traveling in the air. More evidence emerging that coronavirus can remain viable in the air for longer periods of time than traditionally thought, therefore also showing the potential for this to become airborne. And many, many studies, I'm not going to dwell on these, but we have many, many studies showing direct links between airborne transmission and hospital infection rates. So, in terms of dealing with this, in terms of finding a new solution, the challenge with dealing with anything in the air is you must be able to kill it quickly. You have to have a technology which will react extremely quickly and which will kill very, very quickly. So, the technology that we're talking about today, that I'm talking about, is plasma. Plasma has long been recognized as a very, very effective sterilizing medium. If you can now take it, if you can reduce it in size to small mobile units, if you can make it highly effective, if you can make it low power, low maintenance, you now have a technology which you can use in a wide variety of environments, and you have a technology which will kill extremely quickly and therefore be effective in a real-world environment. There's a wide body of research behind this technology. These are just some of the institutions who are involved in the research. You can see the research is spread around the world. And much independent testing, which I want to show you in a moment. I'll come back to the top one in a moment. But testing which was done last year with the University of Huddersfield, and this is one of my central points, using Staphylococcus epidermidis as the focus pathogen, showed in an in vitro testing a kill rate using this plasma technology of over 3,700 colony forming units per cubic meter per second. That's an extremely high kill rate, and it's because the kill rate of plasma technology applied to the air is so high, is because it's effective in a real-world environment. Some testing, I'll jump to the next slide to save time. This is quite small text, I'm sorry. I can show you this in more detail afterwards. But the point here was taking a wide range of pathogens, gram-positive, gram-negative bacteria, gram-positive spores, yeast and mold spores, and viruses, in vitro, again showing extremely high kill rates over 1 hour at high loading rates in the environment. This is some exciting work that's being done between ourselves and NASA, concentrating at the moment on E. coli, although we also are now working with them on Staphylococcus aureus and Aspergillus. You notice live E. coli on the left prior to exposure. You'll notice also after traditional heat sterilization, the E. coli actually maintaining its form and remaining alive, also with ozone. Let me jump to the next slide. This is an E. coli bacteria. And I hear someone saying E. coli is not normally in the air. I understand that, but for the purposes of this testing, we aerosolized it because it's easy to see and hard to kill. So this is a live E. coli bacteria after a single pass through the plasma technology, which we can show to you at the back of the room. This unit is no bigger than a shoebox, and that is the effect. This is a milliseconds, if you wish, millisecond exposure to the technology. Let me pass over that. Fundamentally, the point is people have not been cleaning the air or focused on the air to date because it has not been possible to do it quickly and effectively at low cost. That is what's now changed. That's the paradigm that's changed. It's now possible effectively to sterilize air, to do it quickly, to do it with compact units, and to do it at low cost. So some results in the real world, and I'll go through this very quickly. In Budapest, the largest teaching hospital in Budapest, installation in pulmonology and COPD wards. And since installation, you can see there the statement from the head, the medical director, about the reduction in pathogens, the reduction in outbreaks that they've had since installing the technology. Since putting it into those wards, they've now put it into dialysis and ICU, which is a great testimony of its effectiveness. 9-month study in the Rikshospitalet at the main university hospital in Copenhagen, in nephrology. The Novaris in one unit and the control unit without Novaris. You can see there an interesting effect that the bioburden on difficult to clean surfaces, i.e. windowsills and high surfaces, was very significantly reduced. So in other words, where standard procedures weren't being used, the technology was very effective. But more important, there was a 58 percentage point swing, between the control unit and the unit with the Novaris machines. In other words, infections year on year up 35% in the control unit, down 23% in the unit with the Novaris units. In a large multiple center test with Fresenius, looking at using agar plate testing, 85% reduction in bacteria, 93% reduction in VOCs, and up to 67% reduction in molds, simply by cleaning, by sterilizing the air using Novaris plasma technology. This is what I came back to from earlier on. This was in the UK with the National Health Service. There was a competition arranged to look for new technology to reduce nosocomial infections, and ours was the technology chosen. So there was a large multi-point test done in the Royal Free Hospital in Hampstead. 8,500 air and surface samples at 21 locations around the hospital. We noted a 97% reduction in environmental MRSA, but possibly more significantly, speaking to my earlier point about if you clean the air, you're cleaning everything else, including hands. There was a 75% sustained reduction in surface contamination, simply by running low-cost plasma units. And you can imagine then the knock-on effect of that on hands. This is in very big letters because we're excited about it. We've been chosen by the Karolinska Institute, which, as you know, awards the Nobel Prize for Medicine every year. And starting from March, April of next year, we will be installing the technology in all of the orthopedic operating theatres in all of the major hospitals in the greater Stockholm area to attempt to have an effect on surgical site infections in orthopedics. For us, it's clearly a great endorsement of the technology, and we're very excited about this cooperation. In Jordan, in the specialty, number of the private hospitals in Jordan, we've had very good results in microbiology labs, IVF labs, and operating theatres. The technology has been now working for about 2 years in the USA. It's in almost 400 healthcare facilities, and everywhere it goes in, we're seeing the same results. Nosocomial infections down, respiratory infections down. C. diff, looking there at that specifically in a long-term care facility. In a long-term geriatric hospital in Dublin, I cite this one because there's an interesting side effect in this one. Aside from the very, very positive effects on patients, you can see there outbreaks of MRSA, C. diff, and other conditions have disappeared in 3 years. Individual cases presenting, yes, but outbreaks, no. But there's been a very significant knock-on effect for the staff. We've had an almost 50% reduction in staff sickness. Because clearly, as you're all aware, immune-suppressed patients are not only more susceptible to infections themselves, but they're also greater emitters, greater infectious centers themselves. This, of course, also applies to children and babies who themselves are less protected by their immune systems, but who also are greater emitters of infection of disease. So, finally, an exciting new development that's coming in this year, we're adding real-time air quality monitoring to the system, live sensors which will monitor the quality of the air in real time, give you readouts on your smartphones and tablets, but will also control the machines so that we have a smart loop, giving you data, giving you information on your air quality, giving you information on the potential for infection, but also controlling plasma technology to reduce the danger at the same time. My last slide. I can hear you all cheering. Just to summarize, if you apply air quality technology, if you apply sterilizing technology to the air as the first point in your infection control problem, and you do it effectively, respiratory infections will go down, airborne infections will go down, all infections will go down, and you will have a general improvement in odor and VOC burdens in your facility. If you're going to do one thing to improve infections, to reduce infection rates, clearly it's important to clean hands. Clearly it's important to clean surfaces. But if you're to do one thing which will have a very significant effect and not small incremental effects, treat your air. Treat it effectively, treat it with a technology which is low cost and which works, has been proven to work, and which will work 24 hours a day. The key words being preventative, proactive, prophylactic. Thank you.
Thanks a lot, Mr. McBrien. Monitor, control, protect. Indeed important. An airborne infection technology is a big thing in the healthcare sector. Thanks a lot for sharing his vision. I now request Mr. Upendrajit Singh, Managing Director, West Bengal Electronic Industry Development Corporation Limited, WEBIL, to share his vision with us. So, a big round of applause for him.
Thank you for inviting me here. Thanks to Elets. Eminent panelist and distinguished guest, since I'm from WEBIL, and WEBIL is a state nodal agency for IT and electronics, I would talk about how ICT can, help the healthcare industry in providing more services to the citizens of the country, as well as to the patients. So ICT has been widely used in the healthcare industry for last 1 decade in specific, and generally last 2 decades. ICT has played a major role in the healthcare industry, and there have been a unique kind of propositions by various offerings in the healthcare practice. Specifically, there are a wide spectrum of issues like patient safety, dietary management, telemedicine, digital imaging, document management, etc. And there are, technologies used in the current timings, like the electronic health record, where most of the hospitals are using it, then hospital management system, hospital information system, clinical decision support system. It's something in the telecom, world you use OSS and BSS. So in the healthcare, it's clinical decision support system. Picture archiving and communication system, generally used as PACS, which is for archiving and retrieval of all the digital imaging system, like X-rays and other things. And then barcoding is another area which is used extensively. RFID, radio frequency identification, is also used a lot in the healthcare industry. One thing which is of huge importance is telemedicine, telehealth, which we are also working in a very big way. As a state nodal agency, we are one of the few states which are doing the NOFN project, National Optic Fiber Network Project. So this project is from the Universal Service Obligation Fund. Initially, it was a 20,000 crore fund, which was allocated for rural development and also to have fiber optic to the Gram Panchayat level. This project, there was a SPV formed called BVNL to implement it, and in 4 or 5 years, there wasn't much progress, so the center decided to give it to the states to implement it. So West Bengal is one of the few states which have agreed to do it, and WEBL will be implementing this project for the state. A huge budget for this project, a little less than $1 billion. And we would be, implementing this project. Now, the benefit of this would be, once we have rolled out the optic fiber network till the Gram Panchayat level, with huge bandwidth and network available, the possibility will be enormous. And huge amount of applications, healthcare applications would be run across the network. Telemedicine is one of that, and which will have reach out to the rural area, up to the Gram Panchayat level. And they will have connectivity with the major hospitals, and the remote healthcare facilities will be able to be provided to the remote locations. So that's going to be very, very interesting over a period of time. And this will also, save a lot of lives and give a lot of, importance to the rural area in terms of. Another important area is mobile health. M-health is another thing. Now, if you see, there are major amount of, there are a lot of, hello. So in terms of, creating health dashboards, there are, health dashboards, there are a lot of sensors in a mobile phone where you can, have data, health data, which can be measured and passed on to the doctor for analytics. So that's also quite useful and helpful. And then the most important thing among all is the analytics. Analytics in the healthcare. That's going to play a very large role because the data is there. There's so much of data that's there, but analytics is more important. We are not able to analyze things. So, for example, a particular area in Calcutta, there are a lot of patients having dengue, or likewise, there's some epidemic happening in some area. With analytics, that can be analyzed and that can be, looked at, and likewise, within the various reports, medical reports, using analytics, you can have an easy diagnostic of healthcare. So broadly, with this, I would end my part, and I would just like to say that it's just a matter of time that ICT can play such an important role. And if you had seen Star Trek and the kind of medication these guys had showcased there, it's just a matter of time. You'll have that kind of medication kind of stuff coming up soon. Thank you.
Thanks a lot, Mr. Upendrajit Singh, MD Webel, for sharing his vision on how ICT can be used for healthcare sector. And a big round of applause for Chandima Bhattacharya, Minister of State, Department of Health and Family Welfare, Government of West Bengal. We welcome you, ma'am. Can I ask Priyanka to welcome ma'am with a bouquet, please? A big round of applause for ma'am. She really had a busy schedule today, but she has made it. Thanks a lot, ma'am, for making it for the conference. We'll move on to the next segment, but before that, I think Chandimadi may leave early, so we can launch the magazine, special edition of eHealth magazine, which is covering the Bengal and the eastern part for this issue. Can we have the magazines on stage, which can be launched now? This is eHealth magazine's special issue on Bengal and eastern part of the India on how IT can be used for healthcare service. A big round of applause for this launch of this special issue of eHealth magazine by the Honorable Minister. Thanks a lot, ma'am. Thanks a lot. Thanks. May I request Srimati Chandima Bhattacharya, Minister of State, Department of Health and Family Welfare, Government of West Bengal, to share her vision on what is being done in the state of West Bengal under the new leadership of the CM in the healthcare sector. Thanks a lot, ma'am. We welcome you again.
Good morning, ladies and gentlemen. It's a proud privilege for me to come here today to address this August gathering on behalf of the state of West Bengal. Bengal here, ELATE's Bengal chapter, rather the Leaders Forum, has organized this program, and on the dais are the dignitaries who are legions in the field, who would be apprising you of what are the ways in which the health sector can be developed throughout the country, and especially in Bengal. I am rather privileged to address you here and to give you the facts, what Bengal has done in 4.5 years. We have not yet crossed 5 years of this new government, and it is our Honorable Chief Minister who is leading this department also. She is the minister in charge. There is no other state in the whole country where the Chief Minister himself or herself leads this department, which is the most important sector of a state government. Having a view of what had been the experience of the people of Bengal in the past, new government under the able leadership of our Honorable Chief Minister has really changed the total scenario of the health sector. I would like to give you a few datas which will make the entire picture clear to you. The revolutionary step which has been taken by the health department is that we have made this treatment free in the tertiary level hospitals also. In all hospitals, government hospitals, any sort of treatment, be it operation or otherwise, has been made free to the people of Bengal. As you know, that almost 80% of the people of Bengal, they are actually dependent on the governmental sector, and this is where a revolution has been done by our Honorable Chief Minister. We have set up 107 fair price medicine shops, which has shown a way and has paved a way for the country, because the central government also has appreciated this move of the state of West Bengal and has requested the other states to set up such fair price medicine shops with the help of the private sector. What we are doing is we are giving the land, the electricity, water, everything is being given by the state government in the hospital premises, and the private sector is coming and giving this medicinal facilities there at a very low rebated rate. And this rebate goes up from 48% to 77.2%. In our Ahmed Dental College, the rebate given by the fair price medicine shop is 77.2%. In the RSBY sector, Rashtriya Shastha Bima Yojana, we are actually leading the country. We are the first. And we have built up 33 CCUs at a distance of 50 kilometers and 17 HDUs. And this has gone up to the level of the subdivisions in all districts and subdivisions. And this has been done in just 4 years. 48 SNCUs and 307 SNSUs with 6 PICUs have been opened in 4.5 years. We have been able to actually accelerate the institutional delivery percentage. It was 69.5 when our government came to power, and now it is 85%. We are heading towards building up 41 super specialty hospitals, 34 in the backward region area, and 7 in the non-backward region area, which is being done from the entire, the budget is actually from the state government's coffer, and for these 7 hospitals, nothing is being taken from the central government. And as you know that even for the rest 34, the percentage of central government contribution has now been reduced. But we are committed and we will be doing that from our own budget. Hospital beds have been increased 25,000 in number in 4 years. And we have increased our MBBS seats, increased our BDS seats, and we will be having a good number of doctors within 1 or 2 years. 9 new medical colleges have been set up, are being set up actually, in various districts. And you will be happy to know that when we came to power, if we compare from 2007 to 2011, 4 years, the budget was, health budget was 1,040.7 crores. Now our health budget is 5,159.86 crores. So this is how we have been able to keep our actually commitment to the people of the state of West Bengal, 9.5 crores almost people here, and 80% of them are actually dependent on the entire healthcare system of the governmental sector. So we are trying hard. We need your cooperation. We know that a circle can never be completed unless both the sectors join hands together. And this is where we are inviting private sector also in various fields to come and join hands with the government, like fair price medicine shops, like diagnostic centers, fair price diagnostic centers. So we are happy that here the atmosphere has changed. There has been a change in the climate of the entire healthcare system. and therefore private entrepreneurs also are coming here and joining hands with the state government. It's all because of the vision of our Honorable Chief Minister. And finally, I would express my gratitude for giving me this privilege to come here, address you, and this venue is very near my house. It's only a stone's throw, and I'm happy that you have chosen Park Plaza to be the venue. When you do such programs, actually the locality also gains a lot. So I'm happy that you have chosen this venue. You carry on, and we are here. The state government is always beside these sort of good jobs, and we will be always beside you and doing our part of the work which you require us to do. Thank you all.
Thanks, Srimati Chandima Bhattacharya, Minister of State Department of Health and Family Welfare, Government of West Bengal, for sharing her vision, and perhaps one of the few states where the leaders are coming and asking investors to come collaborate with the state government in all the initiatives. That's a great thing. Indeed, a great round of applause for ma'am. May I now request Dr. Akun Savalwal, Director, Drugs Control Administration, Government of Telangana, to share his vision. He has come all the way from Telangana. Big round of applause.
Honorable Minister, Mrs. Bhattacharya, dignitaries on the dais, especially Dr. Bora, ladies and gentlemen, I'm Dr. Akun Sabarwal. I'm a 2001 batch IPS officer, presently posted in the health department in the government of Telangana. We are the youngest state, we are the 29th state, but we are the state who've owned up Hyderabad now, and I'd like to place on record as they are, thank you. We are the youngest state in the country, but we are the biggest players in pharmaceutical. I head a department called the Drug Control Administration, ma'am. My primary job in this particular department is to regulate the manufacture, distribution, and sales of medicine. And our state manufactures almost 40% of the medicines made in India. We also export about 58% of this medicine. The state, especially Dr. Reddy's laboratories, Hetero Drugs, may manufacture high-end medicines which are basically used in the country as well as exported. My job is also to regulate the prices and the quality of medicines and functioning of blood banks. A lot of doctors here, in fact, when I was discussing with Dr. Bora, how long does it take to get a blood bank license, he said it took us in Assam and Guwahati a year plus. Ma'am, I'm just going to speak about 15-20 minutes. I know your time is precious. I limit myself to the very basics. But we've leveraged technology to try and cut down on the trouble that the government sometimes give to the hospitals, to the industry at large. So I'll be very, very specific. This doesn't move. Okay, a very small basics, ma'am. We have about 490 manufacturing units. In fact, I was just going through the magazine. At one time, West Bengal used to manufacture 80% of the country's medicine. It now does just about 8%. We've grown from the undivided state of Andhra, grew from just about 1 to 2% to about 60% of the country's medicine now. Telangana has inherited almost 85% of that manufacturing capacity. We have about 490 manufacturing units and about 27,000 pharmacists or druggist stores which are functional. So that is my job, regulating all this. And we've leveraged technology to try and do this job. The website, actually, it may appear to be new to all of you, but in the government sector, we are one of the few drug regulators in the country which has put everything online. Our licensing procedures, parameters, the deadlines, the timeline, the flowcharts, everything is on the net. So nobody needs to approach my office to get a license for manufacture or for sale or for or setting up a pharmacy in a hospital. It's done online. Uh, the state government has, in its previous budget session, has passed an act called the Telangana State Industrial Policy Act, in which all departments, including mine, I look after the pharmaceutical wing of the health department. If we are not able to give a license or a permit within a specified period of time, it means financial liability on me and my subordinate officers. So to manufacture, if you have to manufacture a medicine in Hyderabad and you apply to us for a license, and if we are not able to give you a license in 30 days, every day an amount of rupees 1250 is deducted from my salary and everybody up and down the chain who's not been able to give this license. We are the first state to have done it, and I can assure you that over the last 7 months since this act was passed, we've been issuing licenses within 30 days. People from the industry would vouch for me, including the big players, that we've been true to our word. How we've done it, I'll be very brief. We brought in something called timelines and flowcharts. Every licensing procedure is broken down into how long will it take at this particular desk and how long will it take place at that particular desk. We break it down into flowcharts, and that's how every time a file is moved from one desk to the other, it's brought to my notice whether the flowchart has been followed or not. I'll just limit myself to that. A pharmacist in the state of Telangana does not have to go to anybody to get his pharmacy license. He applies online, makes an online payment, we come, inspect, we check the documents over there, and the license is issued. So this is again, we and Gujarat. Gujarat has already been doing it. We followed them, but improved the practice on that. Licensing approval system, I've already said. I'll not go into details. We are the first state which has gone from an area approach into vertical approach. A regulator who inspects a medicine manufacture unit is not specialized in visiting a cosmetic unit or a vaccine unit or a medical device unit. So we are the first state in the country which has broken down area approach. So we don't have this district drug inspector and that district drug inspector. We have drug inspectors who look after manufacturing. Within manufacturing, active pharmaceutical ingredient manufacturing, manufacturing formulations. So we've broken down areas, and now we've got specialized people. We send them to US for training. So all these 6 verticals, they were trained by US FDA officials, and now the US FDA also recognizes the effort that we are putting into training our regulators. E-labs, a big problem is the quality of medicine that is available to the common man in any field. People in the government sector or in the private sector would say, what is the quantity of spurious drugs in your state? Or what is the percentage of, as we legally call it, not of standard quality drugs? Many times people from the industry would vouch that the moment a sample is picked up, one of the representatives follows that samples up to the laboratory. In the past, we've had experiences where the samples get changed, the reports get revised. We've used technology. Now we don't send the sample as such. The moment a sample is picked up from one of the pharmacies in any of the districts in Telangana, may it be Karimnagar, Warangal, it's removed from the packet, put it into a sash, something called a QR code is added to it. It's freely available. It's even available on any mobile phone, on a simple Samsung phone. The sticker put on it, and the sachet couriered to the laboratory in my office. So nobody can follow up which medicine was taken out from one particular drugstore in some particular rural district of Telangana, sent to Hyderabad, and there also everybody who's up or down the line analyzing the medicine doesn't know which medicine it is. So this has led to reduction in the timelines and integrity of testing. Now when I say that 0.9% of medicines in my state are spurious, I can be sure that nobody is played into the system. E-regulation to M-regulation, this is the last thing that I'd like to talk, use of technology. We no more use a pen and paper to go and inspect a manufacturing unit or to inspect a drugstore or to inspect a blood bank. Along with the NIC and the IT department of our state, we've shifted to M-regulation. This is an app in consonance with the Drug and Cosmetic Act 1940, where all the various fields are available online or are available on my own phone or in the phone of each and every. It's any Android phone or an Apple phone on which this app can be loaded. The regulator goes to the shop or to the hospital or to the industry, does the inspection over there, just connects it to a printer, takes the printout over there, signs it, and that's considered a Section 14 or a Form 14 notice regarding improvement. So this has led to a lot of reduction in you see, you could write something while you are inspecting and come back and change it once you get back to office. Here you have to submit a copy to the drugstore or to the manufacturing unit or to the hospital. So it reduces the time because it's immediately issued. Whatever faults have been found in your pharmacy store or in your hospital are given to you then and there. And it also reduces chances of tampering with what was found because the person has been given a copy there and then on the spot. So these are a few initiatives that we've tried in the state of Telangana. I can place on record that as far as drug regulation and regulating the health department is considered, we are now considered the best. A lot of states are taking off from us, Gujarat, Maharashtra, Madhya Pradesh. They are sending their teams. In fact, yesterday I was just sharing with Dr. Bora, even the Health Secretary of Assam wanted to send his team over to us to learn how to do this better. A very, very small presentation, but we've used technology extensively because from myself to the last man on the ground, the Food and Drug Administration in Telangana just consists of about 400 people. So we are a very small team, but we are using technology extensively to try and reform ourselves and to present a better picture to the world of our state. Thank you. Good day.
We also have here the Right to Public Service Act, almost in the nature of the act you said, about industrial policy. And we have been the first, actually, we have talked to e-governance, got the Scotch Excellence Award. This year.
Thanks, Dr. Savarwal. E-regulation to M-regulation in pharma sector. Quite interesting. Ma'am, I'll take you 5 minutes. We have a short award ceremony here. 5 award winners are here. So we'll continue with the inaugural, but we'll have the award ceremony right now. 5th ILITS Healthcare Leaders Awards Bengal 2015. And we thank Honorable Minister of State for Health of West Bengal for being present here and all the panelists for the inaugural. We'll continue with the inaugural session, but we'll have the award ceremony right now. So just to give the overview about the awards, is there on screen? 5th Healthcare ILITS Leaders Awards 2015. We have the award winner with us. Can we have the music also for the awards? Healthcare Leaders Forum Awards objective. The objective of HLF is to examine the value of technology in improving healthcare provisions and efficiency it brings to healthcare systems. It's a platform that brings together healthcare leaders and innovators to share successful new and innovative approaches, first-hand experiences, and lessons learned in plotting this accelerated path to transformation. Selection procedure, the organization's individuals nominated their project through online form. The submissions were verified and reviewed by the in-house award committee members. This was done to ensure that all the fields were correctly filled. The submissions were evaluated according to the stipulated criteria. Selection criteria, as I've said, innovation, scalability, replicability, ability to overcome challenges, achievements, impact potential. It's kind of the music for the awards. So the first category, innovation in healthcare information technology, and the award goes to Robert Bosch Engineering and Business Solutions Private Limited for maternal and pediatric M-Health application. We have Sripriya S., Group Project Manager from Robert Bosch Engineering Business Solutions Private Limited. A big round of applause for Bosch. ताली बजते रहे, हाथ ताली चलते थाकुक. Thanks a lot. Thanks a lot. Yes. This project actually provides assistance to young mothers by completely taking care of both pre and postnatal needs. This application provides point of care delivery which is personalized and relevant to the needs of the mother. That's a great solution indeed. Next is innovation use of IT by a hospital. And the winner is Attune Technologies Private Limited, Attune Lab Information System. More than 277 healthcare centers are using their application. More than 50 lakh patient records has been made in past 2 years with the ability to view the historic data. We have Mr. Partha Sarathi from Attune Technologies Private Limited. The next category is multi-specialty hospital in East. And the award winner is Paras HMRI Hospitals, Bihar. We have Dr. Ravi Shankar Singh, Zonal Director. Paras HMRI Hospital is the first corporate hospital of Bihar, Jharkhand under the aegis of Paras Healthcare. The 350-bedded multi-specialty tertiary care institute with over 25 medical and surgical disciplines has been commissioned in accordance to the tenets of Paras Healthcare affordability, accessibility and quality care. A big round of applause. Government initiative in healthcare, and the winner is Sir Gangaram Hospital, New Delhi for cloud-based pen management platform for healthcare industry. And we have Mr. Niranjan K. Ramakrishnan to receive the award. Healthcare is an integrated e-procurement solution that connects the healthcare organizations along with their processes to the suppliers. Services include all correspondent RFX, bids, auctions, requests, and negotiations. Can we have all the award winners on stage to have a group photo, please?
The innovative technology.
Yeah. तो बंद हो गया बंद हो गया Innovative technology for controlling hospital-acquired infection. And the award winner is Trivector Biomed LLP and Novartis. We have Mr. Dilip Patil and Mr. McBride is also here on stage. A big round of applause. Ma'am, he has come all the way from Germany. A big round of applause for Trivector Biomed LLP and Novartis. Can we have all the award winners on stage to have a group photo? Can we have all the award winners on stage for a group photo? Please come, all the award winners. All award winners on stage, please. And we are thankful to ma'am for making for this event from a very busy schedule. Thanks a lot, ma'am. Now we can have Dr. N.C. Bora, CMD, GNRC Hospital Assam, to share his vision. Okay.
My fellow panelists on the dais, Mr. Upendrajit Singh, Dr. Sabarwal, Dr. Satpathy, and Mr. McBrien. Esteemed delegates, the distinguished resource persons, the ladies and gentlemen present, I must thank ELATS for giving me this opportunity to stand in front of you and share my few thoughts on this topic. I'm a doctor. I'm into the healthcare for almost last 45 years. Was setting up two super specialty hospital in the state of Assam, running for almost more than 3 decades. But at the end of it, I have realized that private healthcare is becoming more and more expensive every day. It's beyond the reach of almost 70 to 80% of the people in this country. We know that recent socioeconomic survey published by the government of India says that 70% of the people in this country, the monthly household income is below 7,000 rupees. So you can imagine what they will do when there is a need for healthcare, especially secondary and tertiary care. So as a result, this 75 to 80% of the people do not have any alternative but to the public hospitals for their healthcare needs. As a result, public hospitals are overcrowded. If a doctor can attend to 20 patients, there will be 200 people waiting in front of him to be seen. So they are tremendously under pressure. There is impossible to deliver quality. Private healthcare, I am one of them, has failed, I would say, as a private healthcare provider. We are one of the service providers in this world who have failed to innovate. As a result, our prices keep rising every day. Look at telecommunication. It was started 20 years ago. A distant call which costed 12 rupees at the beginning now costs us only 1 rupees. But in healthcare, everything keeps rising in 100% year-on-year basis. But the people's income do not increase. As a result, we set up shops and look for patients abroad, whereas millions of people in this country are dying for want of healthcare. Do we think that is it only the responsibility to government to take care of them? Are we supposed to do only business with the rich who can afford to pay you? Who takes care of this 80% of the people if we do not? Why people should respect us? The things that we are running and doing in this country as a private healthcare operator cannot be a solution to the healthcare problem of this nation. It can't be a business model. I would rather say, please forgive me, I am also a private healthcare operator. As a result, I thought, could there be a solution where we can manage quality, bring down cost? Not an easy job. Many people have tried it across the globe, but there was no answer. We have failed. So what I did, I went back to the community. It's a problem of the people. With my own experience of last 45 years, let me go back to the community, relook at the problem with a different perspective, understand what their problem is, what kind of technology they need, what kind of doctors they need, what kind of money they can spend, not what is available in the market at a particular rate. I must look at the pocket of my customers. If I want to be in business, if I want to make a shirt for them, I must make a shirt which fits into their body, which they can buy with the money that they have in the pocket, not what I can produce at particular price. So with that intention in mind, we had a very humble experiment in the state of Assam. We innovated, lot of innovation went on, starting from planning, designing, structuring the building without compromising on quality and patient safety. And as a result, a tertiary health hospital, which cost an investment of around 50 lakhs per bed, we could do it at 25 lakhs per bed. A greenfield project, this is a green building. This is a green building. A greenfield hospital requires around 3 years of implementation time. Assam has got a lot of problem with floods, rains and all. In spite of that, we completed this project in 20 months' time. Not only that, we have seen that this is not healthcare industry that we are working on. This is a sick care industry. You become sick, I treat you, and that's my business. Very simply. No emphasis on preventive and promotive care, especially by the private sector. We think that this is the job of the government. They should do prevention and promotion of health. But the joy of healthcare is preventing sickness and promoting health, not wait for them to become sick and do business. So in this model, what we have done, 500 people work in the hospital, another 500 work in the community. Who becomes responsible for health of the community? They create awareness, they work for preventive and promotive health of the community. That's one. A private hospital, it has to be sustainable, but a equal number of people works in the community for promoting and preventive health and creating awareness amongst the people. Number two, accessibility is a big issue in a hospital, especially tertiary care. We are not able to create tertiary care hospital everywhere and anywhere. Most of them are situated in metropolitan cities, and some of them are going into the Tier 1 and Tier 2 cities, but not everywhere. On an average for a tertiary care facilities, a patient has to travel almost 50 to 75, sometimes up to more than 100 kilometer distance. And the work process, the protocolization in public hospitals are such that I have done that study in Assam, Guwahati Medical College, where I was also working some time ago. I am an alumni of All India Institute of Medical Science. I still go there and see the work process in All India Institute. I study the work process in almost all best of the hospitals in the world across the globe. I have seen that on an average, a person needs to come make 6 visits to complete an OPD procedure. First day he comes and sees the doctor. Then doctor will give him a series of investigation. All these investigation cannot be done in one day. If blood on another day, radiology another day, ECG another day, like that, 4 or 5 visits. Then on 6th visit he comes, collect the reports and go to the doctor. What's the economics of having 6 visits to a hospital from an average distance of 50 kilometers? Along with an escort, if you calculate the economics, each visit does not cost him less than 500 rupees, even by public transport. And that cost him 2,500 to 3,000 rupees only for going and coming. Plus, these 2 persons are not working for the last 6 days. He's just coming and going from the hospital. He must do something every day, otherwise he does not have anything to eat and fall back upon. 12 man days loss. How much does it cause a loss to him economically? Another 2,500 rupees. So the public healthcare system that we are creating in this country, we are not able to improve upon them. I have seen it for the last 45 years. So he loses 4,000 to 5,000 rupees simply in going and coming to the hospital. Even if we make it free, he spends 5,000. Even a person below poverty line is not spared of that. This money is more important for him. He cannot get public transport free just because he has a BPL card. Nobody will give him money just because he could not go to his work and he had to come to the hospital. So, this is what the healthcare is in this country. And in this process, what we have done, we are also creating a network of public transport services between the community and the hospital. And this patient can avail these transport services free of charge. We don't charge them. They come by this transport, they go back to their community by this transport. And when a patient comes, up till now in this model, we do not charge registration fees, we do not charge consultation fees, whether he goes to a medicine specialist or to a neurologist or a cardiologist up till now. He's seen on the same day, all investigations are done on the same day, reports are given to him on the same day, goes back to the doctors, takes the prescription, buy generic medicine and go home in the public transport. This is the model. And the cost of these investigations are almost at par with a public hospital. In West Bengal, it is free. We have not been, many of the state governments are not able to give it free. We have to recover the cost, but we do a CT scan at 900 rupees. We do an MRI at 2,500. We do coronary angiography at 5,000 rupees. for accident and emergency patients, we have 44 ambulances which are placed in different locations in the state. These are free for people, they don't need to pay. And when they come to the hospital, 38 different types of medicines and consumables, which according to our experience are most commonly needed for emergency patients, are made available to them, to these patients, free of charge for first 24 hours. Not only that, some of these investigations, which are most frequently needed for emergency patients, including a CT scan, is given free to these people. And if they need to stay in the hospital, first 24 hours, including an ICU stay, is free for these people. Mind it, this is a private hospital. We get the money from the bank and financial institution and also private equity players. We have to return it, but don't be afraid of the fact that it might fail, where from the money will come. We do surgery, but there is no surgeon's fees, there is no OT fees. We ask them to buy the medicines and consumables, that too mostly generic. And on the profits of what we earn, that's what they spend for a surgery. For example, we are able to do a gallbladder surgery, laparoscopic surgery at 8 to 9,000 rupees. 8 to 9,000 rupees. So, distinguished delegates, my dear friends and colleagues, this is an experiment, a disruptive experiment being executed through lots of innovation in every step of our operations. And even after doing that, we are into the second year of operations. We are going to be profitable in the third year of our operations. So, doing business with the bottom of the pyramids does not mean you make losses. Needs lot of courage, needs sense in the mindset, requires lot of innovations in doing that. And if we all work together in this vision, I don't think healthcare can remain a distant dream for the people of India. Thank you very much.
Now I request Dr. Shujoy Kaur, Director, Medical Services, Apollo Clinicals, to come and share his vision. We are running short of time. I will just request you to finish in 10 minutes.
Namaste. Good morning. I was not supposed to be here. Dr. Rupali was supposed to be here, but she had to take a flight in the morning to be present in a meeting in Delhi. Distinguished dignitaries in the dais, we have heard them all from things that have ranging from infection control to the health economics and how disruptions are happening in many parts of the world, particularly in Eastern India, about how we are looking at the payer-provider balance and what we are actually doing. It wonderful to know the kind of things that are happening back at Guwahati, sir. I bring here, I didn't have a presentation prepared. I bring here a talk which I would like to do, which I sometimes teach at my students at IIT Kharagpur, about 4 distinct paradigm shifts that you need in healthcare at this point of time. And these paradigm shifts are not looking at the cost element as of now, but probably we will build it as it happens. But the 4 distinct things which can probably change the way we look at the relationship between patient and the doctor, between the accessibility, the knowledge perceptions, the change, the innovations that come through, and what the doctors imbibe over a period of time. The first is change the way the medical education is given. The 5 plus 3 plus X is not equal to 40. You have 5 years of MBBS, 3 years of MD or MS or anything, and X years of your post whatever super specialization you do. And then you have a license to practice that branch for next 40 years. What is that we need to bring in as an innovation where there are constant changes? The way the medicine was practiced in 1980s is no more the same way the medicine is practiced this day. There are changes, there are shifts, and we have to bring along them, and how our doctors, not in the tertiary care hospital or secondary care hospital, but in the community, are taking to those changes, taking the challenges of technology, taking the challenges of information, and changing themselves over a period of time. That is one area that we have to look at, because, as I said, 5 plus 3 plus X is not equal to 40, and it doesn't apply anymore. The second thing which I always look at, I also I provide my consultation with Joint Commission International, including sometimes when they have problems with some hospitals related to adverse events. The primary thing that we find in the care process which are problematic are communications. The doctors do not communicate, do not spend times with their patients. They do not say what is going on. They are busy. But in modern day, when people come, even before they arrive to your outpatient clinic, they are half knowledgeable because of the plethora of information that are available on net. You have to provide them with the right sense of the right kind of information in actually to move ahead in that front. So my second point is to get communication at the core of care processes. And we can talk about it and a lot more, particularly in the context of patient safety and improvement. The third is, we have heard since morning technologies, information, and all of that. Again, there's an enormous amount of explosion of this information and technology. And every day you come up with new technology. I remember in I'm an alumnus of Massachusetts Institute of Technology. In that center, 50% of work that is happening on this day is related to healthcare. And everybody from Google to IBM to Biogen to Amgen to Novartis to Pfizer to anybody you name in healthcare is present there and bringing in innovation. Are all of these innovation good? Are all of these innovation perfect? Are the kind of things that we are bombarded with are the ones that would remain as a test of time for the coming next 30, 40 years as a standard of care? That is something that we have to think, pick up, and move ahead in the front. Not all information, not all technology are good. I was thinking of giving a demo, something from my iPhone, but because the time is short, I will not be able to. We talk of eICU. Today, I have MICU in my pocket. There is a technology called AirStrip, which can, at this point of time, provide me with information of what is happening to my patient in XYZ bed number, and his ECG, his bloods, all the records, his X-rays, his imagings are all available to me in a couple of seconds in my iPhone, and I can probably guide the treatment in that. But how are we taking that is something that we have to look at. The final thing that I wanted to talk about is bringing in about predictive analytics in healthcare. Conventionally, the way we have done medical research of non-inferiority, research of saying hypothesis testing has to go. Because we are now piled up with a lot of data across the world, across different regions, on good, valid data coming from the healthcare across, whether it is from the community, whether it is from tertiary care hospitals, because we have been looking seriously into our medical records. Some of them are made into IT systems, some of them are electronic, but whatever it is, we are sitting on a huge database at this point. We can use this data now from an Indian context, use predictive analytics, and do good for the community. Yesterday, we published a study of about 10,000 patients that we did in slum area. This is done by Apollo Gleneagles Hospital and Kolkata Municipal Corporation. Staggering data. 43% of people in slum have hypertension, out of which 23 of them are already having hypertension, and 19% do not know that they have hypertension. And most of these people do not have uncontrolled hypertension because of the fact that they are on a 3-drug or a 4-drug regimen, but they take, on a compliance basis, only 1 drug. Now, this is where predictive analytics can come in, help, look into the big data, and say how we are going to take in front. So these are the 4 definite areas that we have been working on. I'm personally, a couple of my research is currently on with both my alma mater and with IIT Kharagpur, and we're trying to bring in more and more of this into the health system. Thank you very much. Hope you have a nice conference. Thanks for Let's to call us here and do that. Thank you very much.
Thanks a lot, Dr. Shujoy Kaur, Director Medical Services, Apollo Clinicals. Well, at the end of the inaugural session, I will request Mr. Kieran McBride to present mementos to all our speakers. Before you send, I request you to present mementos to all our speakers of the inaugural. To start with, Mr. Upendrajit Singh, MD Webel. A big round of applause. And we had a brilliant inaugural session where we saw knowledge exchange and everything. Thanks a lot for enlightening all of us. To Dr. Akun Savarwal, Director, Drugs Control Administration, Telangana. Dr. N.C. Bora, CMD, JNRC Hospital, Assam. To Dr. Shujoy Kaur, Director, Medical Services, Apollo Clinicals. And now can I request Mr. Upendrajit Singh, MD Webel, to present a memento to Mr. Kieran McBride, Regional Director, EMEA of Inaugural Limited, Ireland. A big round of applause. Can we have a group photo of all the eminent speakers from the inaugural session? Inaugural session was on healthcare policy and initiatives in Bengal, but we had a pan-India touch in that and also the international touch in that. That has been the feature of ILITS conferences all over India and abroad. Thanks a lot, all the eminent panelists for the inaugural session. Now we'll break for 5 minutes of tea because we're running short of time, and then we'll start the next section. Healthcare infra in East, changing paradigms for making healthcare accessible and affordable to all. And I will request all of you to visit the Trivector Expo area. You can see and learn how many solutions they're providing, what kind of technology they're providing all over the world. Thanks a lot. Thanks a lot. Thank you. Thank you.